Are you able to upload your presentation? Wycliffe?
Okay, let me try.
Okay.
Yeah. I don't know, is my screen visible?
Yes, it is.
Go ahead, Wycliffe. You may start.
Okay, that's waiting for. Yes, yes,
So
yeah,
these are
good
give a brief,
afternoon, everyone.
I'll just give a brief intro on why I selected these articles. So these are the first, I would say, attempts made by the Wilshire Institute in US in Philadelphia to try and find out a protocol on how to start treating herpes simplex keratitis or herpes simplex stromal disease. So last class, what I did was I showed you the overview of how viral keratitis can present in different forms, and I showed you that usually it's not just one, it will present as one more than one forms at a time, like stromal with epithelial, endothelial with stromal, or all three present at a time, then you keratouveitis, all these patterns of presentations. Now all over the world there were like case reports that the acyclovir ointment works, some say the tablet works. So when they say tablet, some say 800 milligram worked, some said even 200 milligram worked, some said it worked in adults, some said it worked in children. But then there was no fixed protocol, there was just case reports of, we could hear of people doing some treating one or two patients with their protocol. So this was one of the randomized control trial which was attempted by Wilshire Institute. It is a landmark study. We consider it as a gold standard, and the findings of which helped us answer some very critical questions that actually laid foundations of how to treat herpes simplex keratitis. So now Wycliffe will take you through how this trial was conducted and how the basics of treatment of herpes simplex keratitis were laid. And this will clarify your basic doubts. And from the end of this session, I would expect everyone to understand that what is the first line of treatment you would start in epithelial keratitis and in stromal keratitis. And then after that, I'll take you through in the next class in the complicated scenarios, wherein I'll show you how these management patterns come into picture when the clinical presentation is not straightforward. Okay, so over to you, Wycliffe.
Okay, thanks very much, Dr. Bennett, for that. Good evening, everyone, and welcome to today's presentation. Today's journal club will be presented from Mondola, and the presenter is myself, Dr. Mukupa Wycliffe, and the moderator is Dr. Bennett. The journal club will be on us. The topic of today's discussion will be on acyclovir for the prevention of recurrent herpes simplex virus eye disease. The previous lecture we looked at the introduction. I think we just go through a few points on what I learned in the previous topic, in the previous presentation. So as an introduction, herpes simplex virus eye disease is a eye condition which is mainly caused by herpes simplex virus type 1. It is recurrent with frequent relapses, mainly occurring in the stromal and the endothelium. The primary infection occurs mainly in childhood and is mainly a peripheral conjunctivitis. The virus later gains access to the trigeminal ganglion, where it remains in latency and is later reactivated later on. So in terms of clinical presentations, there are, let's say, three main presentations with a combined one. So the first one is an infectious epithelial keratitis, which can either be dendritic or geographical. Then we have got stromal disease, which could be disciform, necrotizing, or interstitial or endothelial keratitis. Then you can have endothelial in iridocyclitis and trabeculitis. And the combination of the presentation could be stromal or endothelial disease, as Dr. Vinita earlier pointed out. In terms of diagnosis, the diagnosis of herpes simplex disease is mainly made clinical based on clinical appearance alone. But in instances where the diagnosis is uncertain, the investigations can be made throughout other microbial causes, viral, bacterial, or fungal causes of the presentation. PCR and ELISA can be done in corneal and where we use corneal and conjunctival swabs. In case of iridocyclitis, we can do AC paracentesis, which can be sent for PCR or ELISA. But for paracentesis, sometimes the yield is low, especially if the patient has been on a cyclovir. So basically the results may not yield much if you do paracentesis. In terms of management or treatment, the treatment options differ depending on the clinical presentation, as we see later on. And it is based on the hepatic eye disease study, which these studies were done, I think, more than 20 years ago. The treatment can either be medical, where you use antivirals, which can be topical or oral. We can use steroids, as we see later on the head study, they use prednisone 1%, which was used for 10 months and was tapered off with time. In cases of significant scarring on chronic eye disease, surgical management is indicated. In this case, you can do penetrative keratoplasty. For the treatment option, in terms of the type of the antiviral drugs that are readily available, we've got a number of viral agents which are proven to be effective for ocular HSV, but mainly there are about 4 which are clinically available at the moment. We have got trifluridine, which is used as eye drops. This was the first eye drop that was used during the AIDS trial. It is not given normally systemic because of its side effects, and that also it may cause epithelial toxicity on the cornea. Acyclovir can be given as oral or even as an ointment. Then I've got valsiclovir, which is a prodrug of acyclovir. Its bioavailability is better than acyclovir, so it is usually dosed less compared to acyclovir. Acyclovir is also another option, though it is normally not used systemically because of low bioavailability, which is less than 10%, and usually it is present in about a 0.15% gel, which is used topically. So for the HEADS trial, this takes us to the HEADS hepatic eye disease study trials, which are 2. We have the HEADS1 and the HEADS1 and the HEADS2. The hepatic eye disease trial 1 consisted of 3 randomized placebo-controlled trials, which was done between 1992 and 1996. Basically looked at the objectives of the study were to evaluate the efficacy of topical corticosteroids in the treatment of herpes simplex stromal keratitis in conjunction with topical trifluridine. The other purpose was to evaluate the efficacy of oral acyclovir in treating herpes simplex stromal keratitis in patients receiving concomitant topical corticosteroids and trifluridine. Then it was also to evaluate the efficacy of oral acyclovir in treating of herpes simplex iridocyclitis in conjunction with treatment with topical corticosteroid and trifluridine. So the results were that the inclusion criteria, was for patients who are supposed to be more than 12 years old with no active epithelial keratitis. There was no prior keratoplasty of the involved eye. And the results, based on the objectives, the conclusions were, and there was that the topical steroids may be beneficial in speeding resolution of stromal keratitis, but do not affect the VA in the medium term. So in the event that the patient has stromal keratitis, I think it was indicated topical steroids may be helpful in improving vision. Then for the systemic acyclovir was not seen to be useful for HSV stromal keratitis in patients already on trifluridine and topical steroids. Then the third outcome was that conclusion was that potential benefits of oral acyclovir in HSV iridocyclitis did not reach, topical acyclovir was effective in SHV iridocyclitis, but what should be noted is that Statistically, there were just about 50 patients who are enrolled in this study, but based on the trend of the outcomes, because that's why the conclusions were arrived at. Then on the second study is on the hepatic eye disease study 2,
Michael?
which there is two. Yes, Doc.
Yes. So
Am I
just
too
about
fast?
the
Am I too?
heads one study. So let's just bring back to the slide to results. One slide before. Yes, yes. So what is extremely important about this study, and as if Wycliffe has pointed it out, is that initially uh, acyclovir was available only orally in United States. They did not have the topical ointment, which is available in most of the countries. And so they used to have trifluridine eye drops used mainly for HSV at that point of time. And the debate was that what works, whether it is oral acyclovir or is it topical steroids. And if you see, it is HSV stromal keratitis, not epithelial. So the question was, there are three questions which the heads one study answered. And the three questions were, say the patient has a HSV stromal keratitis and he or she is already receiving topical trifluridine. In those cases, will topical steroids be useful? That was the question number one. Then, in such patients in whom you have used topical steroids along with trifluridine, does adding oral acyclovir is useful? That was question number two, because they were trying to set a practice pattern. And the third question was in herpetic iridocyclitis or keratouveitis, who is already under treatment with topical trifluridine and steroids, does oral acyclovir help? So these were the three questions they tried to answer, because the answers to these questions were the direct protocols which you would actually use into the management of patients with stromal keratitis or iridocyclitis. So that was how they went ahead with heads one. Now, if you will see clearly, heads one does not justify that why you should use oral acyclovir. It just says that it might have some potential benefits and probably it is not that significant. But what it highlights is that topical steroids is very important in stromal keratitis. And this is one very important takeaway point over here. And this is what laid the foundations that in stromal keratitis, especially immune stromal, when they are talking about HSV stromal keratitis, they actually meant immune stromal keratitis, because at that point of time necrotizing stromal keratitis was still a dilemma on how to actually treat that. So whatever HSV stromal keratitis is being mentioned in heads one, it is immune stromal keratitis. Okay, Wycliffe, go ahead with heads
Okay.
two.
Okay, thanks very much, Dr. Vinet, for that. We'll go ahead and talk about the heads, the hepatic eye disease study too. This consisted of two randomized placebo-controlled trials. The objectives of the study were to determine whether early treatment with oral acyclovir of HSV ulcerations of the corneal epithelium prevents progression to the blinding complications of stromal keratitis or iridocyclitis. The second one was to determine the efficacy of low-dose oral acyclovir in preventing recurrent HSV eye disease in patients with previous episodes of hepatic eye disease. Then the third was to determine the role of external factors such as UV light or corneal trauma and behavioral factors, such as stress, on the induction of ocular recurrences of HSV eye infections and disease. So based on the findings, to answer the first question, that is the Herpes simplex virus epithelial keratitis trial. In this study, they recorded about 287 studies, but the original plan was to recruit about 502 patients. But this was discontinued after 280 patients. This was due to the lack of suggestion of efficacy of the treatment protocol in the accumulated results. Their conclusion is that in the treatment of acute HSV epithelial keratitis, there was no benefit from the addition of oral acyclovir to treatment with topical trifluridine in prevention of development of stromal keratitis or iritis. Then to answer the second question, this I should emphasize that it's part of our the journal club for today. That is, the long-term sarcopenia is well tolerated and offers a significant reduction in the number of episodes and of recurrences. The third answer was environmental stressors such as sunlight and contact lenses use have not been shown to be associated with the occurrences of hepatic eye disease. So this marks the summary of the heads trials, that's H1 and H2. Then we'll move on to our journal club for today. So the journal for today is taken from the New England Journal of Medicine. The title is the Cyclovir for the Prevention of Recurrent Herpes Simplex Virus Eye Disease. That is the hepatic eye disease study group. It was published on July 30, 1998. The rank and the impact factor were not mentioned. So the objective of the study was to determine whether treatment with 400 milligrams of holocyclovir twice daily for 1 year would prevent ocular recurrences in immunocompetent persons who had had an episode of ocular HSV within the preceding year. In terms of the study setting, the study was conducted, it's a multi-center study at 74 clinical sites. It was done between September 1992 and December 1996. The methodology, which was randomized multi-center placebo-controlled trial of 703 immunocompetent patients who are randomly grouped into two groups. That is group A, which consisted of 357 patients. These patients received 400 milligrams of acyclovir BD orally for a year. And then we had group 2, which has 346 patients who received placebo orally twice daily for the same duration. Then to mask the appearance of both placebos and the actual tablets were the same. That is in order to mask so that the patient are not able to differentiate between the two drugs which were taken. Uh, the inclusion criteria included 12 years, more than patients were 12 years of age or older and had an episode of ocular HSV disease in one or both eyes within the preceding 12 months. Then their disease had been inactive and untreated during the 30 days before the study began. Then the exclusion criteria is that if they were receiving antiviral or immunosuppressive therapy, these patients were excluded. Then history of immune dysfunction, that is renal insufficiency, allergy, or adverse reactions to acyclovir, or history of keratoplasty or keratorefractive surgeries of the involved eye. Treatment for both groups was for 12 months.
Go back to the
Yes.
previous slide? Can you go back to the previous slide? Okay.
Yeah.
So the purpose of this study is, or actually was, to try and find out does does the oral acyclovir help in actually preventing the recurrences? Now, remember in the last class when I showed you that same patient at the end, he had 4 different recurrences in 4 different forms. Like it started with stromal, then it second was an endothelial attack, the third was an epithelial attack, and the fourth was all 4. So basically, if someone is having more recurrences, that means they need, we usually treat them with higher doses of acyclovir. But from where did we get that knowledge or understanding that you actually need to have to treat a patient with a recurrent dose of a prophylactic dose of acyclovir, which is probably half or less than just half of what you give it as a therapeutic dose for a long period of time. So it came out of the findings of this study, and they tested mainly, there are actually, this is one of the study which I would say was a subgroup analysis of heads 2 study, wherein they focused on this one group of patients who were of this specific inclusion criteria, who had more than 12 years of age. Now why more than 12 years of age is because they didn't want to include children. Now children is a totally different, I would say, a scenario in treating HSV keratitis, because any child less than 12 years getting HSV keratitis is considered high risk, and you have to treat it as if the disease is presenting in a high risk cases. So let me tell you, in high risk cases, in HSV stromal keratitis, there are some certain dictums. First will be children less than 12 years. Second will be immunocompromised patients. And the third will be patients who are presenting with bilateral disease. And if you would see, those are the patients they try to actually try to eliminate from their study. So the exclusion criteria includes all of them. And they have also excluded patients who had keratorefractive surgery, because it is actually proven in some studies that keratorefractive surgery actually induces or increases the chances of HSV keratitis, especially in patients who have had a first attack of HSV keratitis. So they wanted to remove all the biases and all the cases which would hinder their conclusions, and that is why this inclusion and exclusion criteria was chosen. So this might not be given, but if you go back and read a lot of studies apart from this during this period, you will understand the context of why this inclusion and exclusion criteria was actually chosen. Okay, go ahead, Mike.
Okay, thanks, Dr. Vinit. Um, the treatment for both groups was for 12 months, regardless of whether there was a relapse or not. The patient and the patient and clinical staffs were unaware of the treatment assignment to avoid bias, and then the compliance and adverse effects were also monitored during the study. So the recurrence of active ocular HSV disease was assessed by an experienced ophthalmologist using a slit lamp by microscopy. This was performed at 1, 3, 6, 9, and 12 months of treatment, and the post-treatment observation period, that is after 13, 15, and 18 months. And the also assessments also done if in an event that there was any ocular symptoms which had developed. And in terms of recurrences were classified either as ocular or non-ocular in nature. Then for the results of the study, this table is just showing the baseline characteristics of the patients. What I should emphasize that in the baselines for both groups, such as acyclovir and the placebo group, they have similar characteristics starting from the get a point. The characteristics were similar. If you look at the study, starting from the race and ethnic group, the sex, and even the type of episodes and type of keratitis that the patient had. So to avoid biasness, I think they had to get patients with similar characteristics in both groups. Then for the cumulative probabilities of recurrences of ocular HSV disease, it was done. The assessment was done according to the Kaplan-Meier estimates. If you check on the graph is showing the placebo and the acyclovir group. If you check the first 12 months, in the first 12 months of treatment, there's a cumulative estimate of recurrence in the placebo was higher compared to the acyclovir, which was about 19% for those people taking acyclovir, and it was about 32% for those one in the placebo group. Then cumulatively, after the full time of treatment, that is to combine the treatment together the observation group, it was noticed that there were about 96 patients who had recurrences, representing about 8% for the placebo group, and 121 about 121 had recurrences in the placebo group, which was representing about 38% of recurrences. For the reasons for early discontinuation, I must emphasize that during the trial, there are patients who are discontinued with the study. The reasons were ranging from patient decisions unrelated to side effects, then others were because of side effects, then the third one was because of incomplete follow-ups. The cumulative total for those on acyclovir were about 70 patients who are discontinued for various reasons, which represented about 20%, and 58% patients had discontinued for various reasons in the placebo group. For the recurrences of ocular HSV disease during the 12 treatment period, um, the conclusion that we can drive from this table is that there's a correlation. If you check here, depending on the number of previous recurrences, there's a correlation between the number of recurrences and there's someone talking, and recurrences in the study. If you check the more number, those who had about more than 4 recurrences are the higher number of recurrences for both the acyclovir and the placebo group. So the conclusion can drive from this is that the episode has a strong associated with likelihood of recurrences, whether there's someone on placebo on acyclovir treatment. For the author's interpretation, the authors concluded that long-term treatment with acyclovir helps prevent recurrences of ocular HSV disease and orofacial infections in patients with a history of ocular HSV disease. This reduces the likelihood of corneal scarring and loss of vision. And then that acyclovir treatment was generally well tolerated and there was no serious adverse effects, and that the benefit was not sustained after treatment was stopped. Well, if you check in the observation group, I forgot to include the table. I think after the discontinuation of the treatment after 12 months, it was noticed that the recurrency rates of the infections were almost similar for both those who are on taking acyclovir and those who are on the placebo. So that's what led to the conclusion that there was no sustained benefit after treatment was stopped in this study. And in terms of the Marie critique, in terms of the methods which are used, the study design, the study period, and the sample size were given. The inclusion and exclusion criteria was stated. There was ethical approval which was obtained for this study. For the assignment, it was more centered randomized placebo-controlled trial of 703 immunocompetent patients. Participants were randomly selected into 2 groups of placebo and those on acyclovir. The end of the study was answered, and the follow-up of patients was good. For the results were presented, though they did not like present in table form for those who are non-ocular side recurrences, because if you notice that the only thing emphasis was on the ocular recurrences, but there was no much mention on the non-ocular infection, no table presentation for the non-ocular recurrences. The sample size was adequate, I think at about 703 patients, and all subjects were of different ethnicity. And then in terms of interpretation, the long-term treatment with acyclovir helps prevent recurrences of ocular HSV disease and facial HSV infections in patients with history of ocular HSV. For extrapolation, looking because all stresses were included, I feel that acyclovir can be used in prevention of recurrent herpes simplex eye disease in our setting. But however, we should take note of the cost and the benefits of this treatment, because imagine a patient being on acyclovir for 1 year, it comes at a cost. And according to Lyson, as we'll see later on, there's this study which was done by David Lyson and et al., which was looking at the prevention of herpes simplex eye disease, the cost-effective analysis. And their conclusion was that hepatic eye disease is costly to treat and prevent, and because of prophylaxis, oral acyclovir is not cost-effective option for all patients with previous HSV eye disease. Therapeutic decisions must be made on a case-to-case basis. I think this marks the presentation, the end of my presentation. Unless there are any questions or clarifications or any contributions to be made.
Very, very nicely presented, Wycliffe. Fantastic effort. And very nicely you have brought out the points. And actually, I would like you to take back to the author's interpretation slide, which actually puts forth 4 extremely important points that actually help us even till date in understanding why we are using acyclovir. So yes, this slide, yes. So if you read the first line, it says that the long-term treatment with acyclovir helps prevent the recurrence of the ocular disease and the orofacial HSV infections in the patients who already have a history of ocular disease. Now, this is a very important point, because from where did they get this conclusion was because of the inclusion criteria, wherein they took in patients who had the history of recurrence in one or both the eyes. And if you see the next point, that actually shows how does it actually prove beneficial. And it proves beneficial by decreasing the corneal scarring which occurs in the center of the visual axis along with vascularization, as I showed you in the last class, which further leads to a leukomatous scarring with vessels, leading to loss of vision. So it is going to prevent that, or it is actually going to slow this process down. Now, if you remember last time when I had actually pointed out that there are two types of reactions occurring in the body when there is a attack of immune stromal keratitis. One is which is occurring due to the systemic reaction, wherein the body's immune response is hyperactive against the viral say HSV DNA or the protein structures which I had shown, and that systemic response is in some way partly related to the recurrences, because this virus stays dormant in the trigeminal neuroganglia and the nerves, and whenever stimulated under stressful conditions, the immune response against the virus gets activated. But I also showed you that there is a second pathway to this, wherein there are local antigen like substances, lat proteins, LATs. So these lat proteins and sequences in HSV, they lie dormant inside the corneal stroma, and they are also equally responsible for the local recurrences of immune stromal keratitis. In fact, the iridocyclitis and endothelitis would probably be related to a systemic response. But when it is stromal keratitis, it is most likely supposed to be due to the lat protein. And this is where topical steroids come into picture, where topical steroids are actually trying to decrease the local reaction against these lat proteins, and both in lat proteins as well as the systemic response. But the oral acyclovir is going to decrease the systemic reaction, and it will also clarify if any dormant active viral cells, if they are present. So if you see now the last line, which says that the benefit was not sustained after the treatment was stopped, this exactly tells you the point that if acyclovir was stopped after some point of time, then the body was capable enough to develop a systemic response again, which led to recurrence of stromal keratitis. Correct. So there are two factors. One is a local lat protein response, and one is a systemic response from the body. And topical steroids and oral acyclovirs are working in hands together to try and defeat both of these pathways. So if you understand this mechanism, like how I explained in the last class, and now if you see the author's interpretation out of this study, then the puzzle will start becoming a little clearer to you, that what is exactly that we are trying to treat in an HSV stromal keratitis. Also, one very important point that came out of the study was that acyclovir treatment was generally well tolerated with no serious adverse events. This is a huge plus point, because some patients are on prophylaxis for oral acyclovir for months and years together. In fact, if I mentioned you those three high risk cases: children, bilateral cases, immunosuppressive scheme. So in those cases, you need even a long-term prophylaxis and even higher doses. If the recurrences are more, then you need to give higher doses of recurrence, acyclovir prophylaxis. Usually, out of this study, they found out that probably a dose of 400 milligram 2 times a day was actually good enough to sustain a prophylaxis. There are some other studies also which tell you about the dosages, but in this study, they focused more on the duration part and the efficacy part. There are some other studies which showed us about the dosage forms. And if you would see one of the graphs that Wycliffe showed initially, you would actually see that in the placebo group, the most number of recurrences were within the first 3 months. So it is extremely important that you give oral acyclovir immediately after first attack or whichever attack. It has to go on at least for a 6 month period. Because why 6 months is, if you see in that placebo group and in oral acyclovir group, the recurrences after 6 months are absolutely less compared to what happens in the first 3 months. And that is the important. So Wycliffe, if you can take the next slide. A very good analysis of Mari Wycliffe. Only a few things in this, wherein these um, the results part and interpretation part is more like the interpretation and extrapolation is where what do you think about the study and where you would like to apply it. So there is one author's interpretation and author's extrapolation, and the Mari gives you a privilege to actually give you your own opinion, wherein what do you think about uh, uh, the whole study, and where do you think the findings of this study will help you in your clinical practice. So just those were the small points which I had to make. Rest, the whole presentation was very good. We can actually take some questions, doubts. I wanted to keep this very simple because I wanted to discuss only the basics. And if Wycliffe can show you the last slide where we actually try to just show you a paper of cost effectiveness. We didn't want to complicate it too much because uh, too many studies, then it's difficult to take away a good take home message. So this study is important
Yeah,
because
Dr. Vinet, may I just interrupt before you come in?
yes,
Yes, please ensure that your mics are muted. They are disturbing the presenters. And then we have two participants who have not put the names in full despite messaging them directly. Stella and Lombe, kindly put your names in full so that the person getting the register can record you.
thanks, Dr. Mumbai. So this study basically was actually put forth because they, once you start treating a patient on a prophylactic acyclovir dose, that goes on for months. Like as I told you, minimum of 6 months. And if you would see the cost effectiveness of treating a patient only on those 6 months, it's huge. And if you see that oral acyclovir costs almost $8,532 per ocular HSV episode averted. So that means if you are actually preventing one episode, then oral acyclovir was actually, they are saying that it could be even more costly, but even the treatment itself is also costly. So this was the major problem with acyclovir in United States. They did not have a they still don't have a topical formulation. It was recently launched last year, a 3% acyclovir ointment. And like India was quite lucky to have this formulation pretty earlier. And there are some studies published on efficacy of acyclovir ointment compared to oral acyclovir for treatment of epithelial disease. And we will discuss about these practice patterns in the next class, wherein I will bring about different treatment protocols that can be used in HSV epithelial and stromal keratitis. But on the outset, I would say that in epithelial keratitis, you can actually walk away with treating with just an ointment instead of starting tablets.
Elvis, yeah, you may proceed. Sorry about that.
No, it's okay, no problem. So in epithelial keratitis, we can get away with using an acyclovir ointment rather than jumping to oral medications, which are on a costlier side, as you can see in this paper. And acyclovir ointment is actually quite affordable compared to the tablets. And the dosages, I'll tell you next time. It's the same dosage as we use for the tablets. It really works well, especially in epithelial keratitis. But when the stroma is involved, efficacy of efficacy of ointment is a little, I would say, not clear. It might work, it might not work. There are some case reports that say yes, it does. There are some which say it doesn't. But the efficacy of oral acyclovir in stromal keratitis is definitely proven, and it's not through the heads trial per se, but there are some other studies where they have actually proven this. So I will bring about all these points, that why topical steroids is a very important part of stromal keratitis, and you should not taper them very fast, especially in HSV stromal keratitis. All those points, though they did not come out from head study, they came out through some progressive studies which were done after this head study. But this head study, so the head study was primarily done to bring about a basic understanding about how to treat HSV stromal keratitis. And if anyone has doubts, they can ask, because these two studies, these three studies, you can go back and read. They will actually, you know, answer a lot of doubts which you had basically about why you particularly treat a patient like this and why you don't. And there are remaining questions which I will take over in the next class, which is a more practical oriented class in how to deal with each complicated case scenario. So Dr. Mumbi, any questions that you would like me to answer? Any other doubts regarding HSV keratitis management, basic management, and an excellent
So
job
far,
by Vaishnav.
yes, yes. So far, I cannot see any questions from the chat box. Please, if there's anyone who needs to ask, you can just unmute yourself and ask or type a question. An excellent presentation, I must say, from Wycliffe. I think it is well done. I've never understood these topics that have been confusing me for quite a long time, like I have today. So,
One question, Mumbi.
yes.
Is there a benefit for use of topical steroids in addition to the oral cyclovir for prophylaxis in stromal keratitis, and for how long can they be given? Excellent question. It's been asked by M. Funjika. So for prophylaxis, especially when we are giving acyclovir for 6 months, so there are some studies which say that you cannot stop topical steroids, wherein they say that you need to continue them for once daily for say 2 months, and then continue it probably alternate day. But in our practice patterns, we have found that this actually leads to inadvertent use of topical steroids, and we have seen patients standing up with steroid induced glaucoma and some real problems. So what we do is we treat with topical steroids, tapering dose for some amount of time, say 6 weeks taper, but a slow taper. So 6 times a day for 2 weeks, 5 times a day for 2 weeks, 4 times a day for 2 weeks, like that. We taper it slowly, and once it reaches 1 time a day, we kind of try to extend it for some more time by cross checking the intraocular pressure. And for oral acyclovir, the first 2 weeks we treat with 5 times a day, and after the first 2 weeks we immediately start the prophylactic dose. So the use of topical steroids is depends from consultant to consultant, but you have to be sure that you're taking care of the IOP and steroid induced glaucoma. That's extremely important. Steroids are an extremely crucial part of treatment, and they need to be given judiciously in the first 6 months.
Dr. Vinit, I was wondering on the steroid,
Yeah.
considering those patients who are steroid responders, are there any studies, or do you sometimes give other steroid-sparing drug like cyclosporin or tacrolimus?
Yeah, very good question. So again, cyclosporin, tacrolimus can be given, and they do have some efficacy. But if you see, they take a long time to start action. So again, initial period of using topical steroids is again justified. So in that period, you can always start a steroid sparing drug and you can continue them. We have actually given to some patients tacrolimus ointment and it works well. Cyclosporin to that matter, initially it was started as oral, but oral is again expensive. It adds to the cost. So topical cyclosporin has been used. There are some good studies which have been done, but again, I would say that steroids works the best. And if you have a problem of steroid induced glaucoma, you can still get away with a surface steroid, a soft steroid like loteprednol, but that is actually more capable of diminishing the chances of recurrence in the early stages. Yes, cyclosporin and tacrolimus will definitely work in long term. Once it almost takes uh, 6 weeks to 3 months for it to start the action, and once it starts, then you shouldn't stop it. So you have to be very clear that if you're using cyclosporin and tacrolimus, it's going to be for a long time for the patient, and then you will have to consider those costs. If that is fine, then we can definitely go ahead.
Any more questions? Any clarifications? Okay, so there's another question. When do you commence topical steroids?
So the day you diagnose that there is an attack of HSC stromal keratitis, stromal. So in that case, the first day itself, you will start topical steroids along with oral acyclovir 5 times a day. But if there is an epithelial disease component, then things get complicated. Because if you add topical steroids, it's going to worsen. Once it worsens, and if the epithelium doesn't heal, then the stromal disease is going to get worsened. The whole idea of using topical steroids is to decrease the immune response and the chances of recurrence. But if the epithelium doesn't heal, the stroma will anyways get damaged. So in those cases, you have to really see. I'll show you some good cases. In those cases, it's the acyclovir that actually works the best alone for some period of time, along with lubricants to allow the epithelium to heal. And once the epithelium heals, then you can start topical steroids. Those are the two important things. But some really important scenarios which I will bring about in the next class is where you just cannot miss topical steroids, and those are the high risk cases wherein, like I mentioned, children, bilateral diseases, multiple recurrences, presence of uveitis, all those things are extremely high risk cases.
Yeah, just to marry Dr. Tembo's question about steroids, which steroids would you particularly recommend to start with?
So we can start with prednisolone acetate 1%, and that works very well. But again, be cautious about intraocular pressures. Prednisolone acetate is known to cause high pressures. People have used dexamethasone also in the past. Dexamethasone antibiotic combinations were also used in the past, but dexamethasone is more likely to cause an increase in intraocular pressure. Apart from that, there are some long-term acting steroids like difluprednate, but prednisolone acetate is by far the most common drug that's being used.
Yes, thank you for that. Do we still have any questions? Dr. Moka? Any questions, comments? Okay, so as we wait for another question, how much is the highest dose you have given in some of these complicated cases you had mentioned earlier?
Okay. Um, yes, Mumbai. So your question is, what is the highest dose that we have given?
Yes,
Usually, yeah.
considering that these drugs have renal toxicity.
Um, so I know of one thing that the rates of glaucoma and IOP rise in IOP is very high in your part of the world. That's why I keep raising this point that you have to check the intraocular pressure. Uh, but to begin with, we always start with 6 times a day, and if it is an extremely severe reaction, maybe you can start up to around 8 times a day. Um, it really doesn't depend on the body weight or anything like that. It's more to do with how is the presentation, like uh, is it like a fourth recurrence, fifth recurrence, or is it bilateral disease? So all those things you need to weigh in, that this is more tending towards high risk case. That means we need to start with a higher dose rather than treating with the highest dose. What really works is using it for a long period of time. So avoiding to taper too fast and tapering it slowly over a long period of time actually helps much better than giving a higher dose over here, because this is not a primarily connective tissue inflammatory disorder of the body, like peripheral ulcerative keratitis or Moran's disease, which are like really inflammatory diseases of the eye. This is an infection which is mimicking like an inflammatory disease in the part of its course, and then it again jumps back as an infection. So it doesn't need a high dose, it needs a high longer duration. That's the catch basically.
Okay, thank you. There's a question from Dr. Asia. What have been the success in using the steroids?
The success rate is good. It actually helps in preventing scarring in the initial stages. You can actually see the edema of the stroma going down, and the patients notice a drastic improvement in vision with that, especially in the first 2 weeks, and they are symptom free. So all the symptoms of pain, redness, watering, they all go away. So it works well, and you need to taper them down slowly, and over a period of time you can actually stop it by continuing the prophylaxis of acyclovir.
Okay. I'm not seeing any questions or any hand that is raised. I'm assuming everything has been explained to the satisfaction of everyone. Yeah, just in case there are any questions that you remember later on, you can keep them for the next presentation. So we still have Dr. Vinit is going to be with us again in the last part of the 3 series of the presentation we have had. So we made it deliberately that the first part we did introduction, and then today was one way of making the presenter also participate and talking about the heads. And then the last part, as earlier discussed, we are going to do the complications. So we will communicate to you and send a link for the similar presentation. Just in case you missed out something, you can still go back to these lectures so that you can cement your understanding. Any
Yes,
closing? Yes.
I really apologize for coming in 15-20 minutes late. I was actually driving back home, and I got stuck in a really bad traffic jam due to rains. There were unexpected rains today all over Hyderabad, and it was really bad. And I think Mumbai knows when it rains here, it really rains very badly, and the whole thing gets stuck. So really, I apologize for that. Really sorry.
Yes, no, we are glad you were able to make it in time. At least everyone has been able to benefit from your moderation. Apparently, I think also Wycliffe also had a lot of rain. I think the rains ended. At the beginning, when you were chatting with him, there was a lot of noise in the background. Okay.
Yes.
Yeah. So any closing comments from anyone, and then we'll allow Dr. Venix to close from the presenter and any person in the house before we close.
And from my side, I just want to thank Dr. Vinit for the moderation and for sparing time to teach or to guide me during the presentations. And thanks everyone for attending the webinar this evening.
Okay, thank you.
Thank
Dr.
you.
Vinit.
Very nice attempt. It was a fantastic attempt by you. Very nicely done presentation, and very fluid and nicely brought out clinical points.
Yes. Okay, thank you very much, everyone. And please join us again for the last session on HSV keratitis. Okay, bye. Thank you.